Hi, I want to thank Hallie Farber, Dr. Minkoff, and Catherine Hunt for involving the genetic counselors and myself in this talk this morning. I'm happy to be here. I am going to be talking about test results, their significance, surveillance, and some other basic things. As everyone has alluded, the test results are sometimes very difficult to interpret. We have different flavors of test results. If you say they can be negative, they can be favor polymorphism, they can be positive, or they can be a genetic variant of uncertain significance. And many times as genetic counselors, we get patients referred to us whose medical providers have drawn their results and get back one of these things that they don't know how to explain to the patient. A negative result, if this is the first person who's been tested, we found no mutation in either the BRCA1 or 2 gene, that first person who's tested may still be at risk, especially if there's someone who has a strong family history of cancer, they have cancer themselves, they were at an especially young age, and so we're not going to completely tell them that they're out of the woods, nor their family members. They may have a higher risk than some other family. Their sisters and brothers may still have a higher risk than some other family, but we didn't identify the genetic cause for their cancer or the cancer in their family. If we're actually testing someone for a known mutation, someone had previously identified earlier, and then one of their relatives tests for that mutation and they're negative, they are a true negative. Now, that doesn't mean that their cancer risk goes to zero. It simply means that their cancer risk is now the population risk. They're out of the very high risk category, but they're in the average category that Chelsea spoke about. Favor polymorphism. This usually only comes up if I forget to discuss it with a patient. But what it means is that a change in the gene has been identified. The genetic testing laboratory does not believe that it is a cancer-causing mutation. There are certain places within the gene where there can be a change in the sequence which does not affect the function or the protein that's produced by that gene. So I think of it as a cosmetic change. I think of it as the difference between my best friend and I went out and we each got new Maseratis. She got red, I got white. It's really not going to affect how we drive our cars. Probably still kind of crazy for both of us. A positive change means that a harmful change or a deleterious change, the big word comes out on that test result. Positive means we did find a change that has been proven to cause cancer and that this individual is now at increased risk to develop cancer. If they're testing for this mutation that's been identified previously in the family, I always stress that this does not guarantee that they will have cancer, but they have a much, much higher risk. They may want to consider increased prevention strategies or surveillance or different types of things that we know are effective in reducing the risk. Okay. A genetic variant of uncertain significance. Every once in a while, we have an individual come through the door, tests, and it's reported back that a mutation has been found in one of the 2 genes that has not been seen very often in most of the population. Usually there'll be an accompanying report that'll say that we saw this so far in 5 other individuals who were of Hispanic descent, and that a certain number of them had cancer, a certain number did not. With a very low number of individuals who have been found to have this change, that isn't enough to be statistically significant and say that we know this is harmful or we know that this is not harmful. And so typically what's happening in those situations is that the testing laboratory will then offer testing to other family members, the parents if they're living, other individuals in the family who may have had certain cancers at a certain age, and try to decide whether or not this is something that is actually tracking with cancer or not. At a certain point in the future, this is generally reclassified as either harmful or harmless. I've seen that happen within a couple of months, and I've seen it happen within 2 to 3 years. So it's something that we have to cautiously counsel the patient about And we have to counsel the patient in the context of the family history. If this is something that comes up and you have got 5 people in the family who are first-degree relatives who all had breast and ovarian cancer at early ages, I'm going to be much more cautious in how I counsel that individual. They may still be advised to do more frequent screening and surveillance until we know something different. Treatment options for people who test positive. This is an actual couple of young women that I saw very early on when I moved to Phoenix. And the young lady on the left tested positive for familial mutation. Her sister tested negative. Their mother had passed away by 40 years old of breast cancer. Several aunts and grandmothers had had breast and ovarian cancer. There were a cousin that were affected, many people who had been affected at very young ages. The woman on the left chose to have preventative mastectomies with reconstruction. She had already had her children. She was in her mid-20s. But for her, the choice was very simple. She intended to be there for her children and her grandchildren for many years to come. Later, she went on to have preventative removal of her ovaries, and again has reduced her risk for those typical cancers by about 95%. Her sister tested negative, so she is at the population risk, which means that she still has about a 12% risk for breast cancer over her lifetime and a 1.5% chance for ovarian cancer. But it allowed them to make some choices. We also counsel people that certain types of chemoprevention can be effective. Certain oral contraceptives can reduce the risk of ovarian cancer. Certain medications such as tamoxifen can reduce the risk for breast cancer. It is not a one-size-fits-all, but we try to give the patient information, try to make them aware of studies, give them a lot of information, and really empower them to have the discussions with their medical providers about what is right for them. Surveillance is again going to be based on the personal and family history. If we have someone who was diagnosed with breast cancer at 39, we found no particular genetic mutation for her, I'm going to tell her that her sisters, her daughter, should all start breast cancer screening, such as mammograms, about 10 years earlier than she was diagnosed. The same thing for the ovarian cancer. There is very limited ovarian cancer screening. It is not great, but we still recommend that people start doing things like a CA-125 along with a pelvic ultrasound. CA-125 blood testing looks for the presence of a particular protein, such as the male PSA test, but it is not specific for ovarian cancer. If you have endometriosis or fibroids, you can have an elevated CA-125. It can be very helpful to follow a woman that we know has ovarian cancer, is receiving chemotherapy, and we're watching the levels drop as her cancer is being treated. We may need to do multiple different types of screenings, and again, it's going to depend on your age and what the family history was. These are some of the support groups that we have available either here in the Valley or on a national level. Bright Pink was started by a genetic counselor, and they have multiple booklets and resources available for many different groups. Sharsheret is a very good one here in your Jewish community. Force, Facing Our Risk of Cancer Empowered, is people who have been diagnosed with BRCA mutations or people who have received negative test results with very strong family histories. You'll see the Shalom Center, you see the Jewish Family and Children's Center. The wellness community provides many great programs here. Another one that we have that is very good is Bracketeers. Bracketeers meets the odd months at the wellness community, but at different locations, and the wellness community brochure typically tells where it's going to be during those months. Genetic counselors are present there. They're meeting with people that have been diagnosed with BRCA cancers or are BRCA positive, and they provide a lot of different things, anywhere from strategies about medical management to yoga, to doing different things as far as talking about what's up and coming in the news. Is there a breast cancer vaccine coming up? Just kind of sitting around and helping people really become more empowered by more information. And there was supposed to be in your handout some of the different breast cancer support groups that are available here in the Valley. If you go to a breast cancer group and it is not to your liking, try a different one. Some of them you can call up ahead of time and sort of find out what they do. Some are for the younger women, some are for older women in general. Obviously, a young woman is going to have different things to talk about at age 30 than someone who was diagnosed at age 60.